Dear colleagues, I am Christoph Diener from the Faculty of Medicine at the University of Duisburg-Essen in Germany. And this month I would like to concentrate on the new treatments for acute migraine attacks and migraine prevention. I think you are all aware that we have a number of new drugs, both for the acute treatment and for migraine prevention. Unfortunately, almost all of the publications dealing with these new substances were supported by industry. And therefore, the International Headache Society decided that we wanted to have a series of independent papers written by young headache specialists without conflict of interest. And these 8 papers were published in Cephalalgia in March 2023, and they are freely accessible, they are open access, and you can easily read them. Let me start with the new drugs for the treatment of acute migraine attacks. Standard therapy is analgesics, NSAIDs, and triptans. And now we have 2 new classes of acute drugs. It's lasmiditan, which is an agonist at the serotonin 1F receptor and works centrally. And then we have 2 gepants which act on the CGRP receptor. This is rimegepant and ubrogepant. The first study summarizes the results from 7 trials with 12,800 patients, and all active drugs were superior to placebo. The most effective new treatment was lasmiditan, 200 milligrams, but this drug unfortunately has a number of central side effects, in particular concentration problems, tiredness, dizziness, vertigo, and the drug cannot be taken if you have to drive a car in the next 8 hours. Rimegepant and ubrogepant have very few side effects, but in indirect comparisons they are less effective than the triptans. The second publication deals with open-label and long-term and observational studies with these new drugs, and there are no surprises in terms of efficacy and adverse events. Ubrogepant in 2 patients showed increased liver enzymes, but it's not clear whether this is a causal relationship. And the new drugs were effective also long-term in open-label studies, and there was no sign of tachyphylaxis. The third publication deals with the value of the new migraine drugs in patients who do not respond to triptans or have contraindications for triptans. There are post-hoc analyses from the published trials which indicates that most probably these new drugs are effective in triptan non-responders, but we have no dedicated randomized trials in patients who are identified non-responders to triptans. And it seems that these new drugs, at least in open-label studies, are safe in people who have cardiovascular diseases. And it is possible to combine, for example, the gepants with monoclonal antibodies against CGRP given for migraine preventive therapy. The fourth paper deals with the efficacy of monoclonal antibodies against CGRP or the CGRP receptor, and gepants like rimegepant and atogepant for migraine prophylaxis. We have 19 studies with more than 14,500 patients for erenumab, eptinezumab, galcanezumab, and fremanezumab, and most of these studies were in episodic migraine and a few in chronic migraine. For all 4 monoclonal antibodies, there is clear efficacy and clear superiority over placebo, and these drugs are very well tolerated. Rimegepant 75 milligrams every second day is also effective in migraine preventive therapy, but in indirect comparison, it's less effective than the monoclonal antibodies. The 5th paper deals with the safety and tolerability of the monoclonal antibodies against CGRP and gepants. Here we have also 19 trials with 14,500 patients, and it showed that these drugs are generally well tolerated. The highest adverse event rate was with 100 milligrams of atogepant and 240 milligrams of galcanezumab. Otherwise, there are no major differences between the monoclonal antibodies in terms of tolerability and safety. Erenumab has a slightly higher risk of constipation. The 6th paper deals with the role of these new migraine preventive drugs in patients who did not respond to previous therapy, for example with beta blockers, flunarizine, topiramate, amitriptyline, and so on. And it shows in dedicated trials that all of these new drugs and new monoclonal antibodies are effective in people who did not respond to prior therapy. The seventh paper deals with the role of these new migraine preventive drugs in patients with chronic migraine with and without medication overuse. And we have here again studies that clearly show that the subgroup of patients with MO and MOH responds to these new therapies, but these were all post hoc analyses. And I think we should use these drugs in particular in patients with chronic migraine and medication overuse. At present, we have no data for rimegepant and atogepant. And the eighth paper deals with long-term and open studies for the monoclonal antibodies. There are 13 studies for the monoclonal antibodies and 1 for atogepant. These observational trials lasted up to 260 weeks, and there were no new findings in terms of safety or adverse drug reactions. Over 75% of patients use these new migraine preventive treatments after 1 year, and there is no indication of loss of efficacy over time. There was a separate paper also published in Cephalalgia, meta-analysis of studies with the new monoclonal antibodies topiramate and onabotulinumtoxin A in patients with chronic migraine and medication overuse headache, and the monoclonal antibodies were effective. Onabotulinumtoxin A was effective, but the data for topiramate are relatively poor because these trials were done a long time ago. So, dear colleagues, it's really worthwhile, if you have time, for example, on the weekend, to access these 9 papers and read them carefully and hopefully learn a lot about the new ways how to treat migraine attacks and migraine preventive therapy. Unfortunately, the new treatments at present are very expensive and therefore are limited to only a small number of patients. I'm Christoph Diener from the University of Duisburg-Essen. Thank you very much for listening and watching.